This conference will now be recorded.
Assalamu alaikum wa rahmatullahi wa barakatuh. In the name of Allah, we'll start the session number 7 for September 2020 exam. Today we'll discuss 3 important topics for the exam. 2 topics I think you like: chickenpox and group B streptococcal infection in pregnancy. And we'll start with audit because I think most of you don't like audit because it looks a difficult topic, but sometimes in the exams there would be one question, a single best answer regarding this topic, and you know that you have already 200 questions. One question could help you to pass the exam, and maybe you need only this question to pass. So every question in the exam is important. We'll start first with topic audit, with the audit topic. And the start, this is just the story of the one of the first audit was undertaken by Florence Nightingale. This is British girl. She was born in Italy, and she is interested since she is young age to be a nurse. The first contact with the nurses was in Cairo, in a school in Alexandria, Egypt. This was a hospital, was run by Roman Catholic Church. There, the hospital was crowded. She mentioned in her book that there was about 19 nurses only, but the work was very organized and they can do work for 90 nurses. If possible, you can mute your mic through the screen because we will waste much time if we will press every time to mute all. It will be difficult. So in this hospital, she recognized that any hospital, if there is system, this would be very essential for the patient care. And even she visited frequent towns in Egypt like Qana and Aswan, and she wrote a book about Egypt called Letters from Egypt. After this, she traveled back to UK, and there was a war called criminal war. In this war, the mortality rate in the hospital was very high. Actually, the soldiers was not die from battle wound. No, they died of infection like cholera and typhoid. By help of Florence, she tried to check why the mortality rate high. So this means that the infection in the hospital more risk than the battle. The hospital itself is a risk factors for the patient. So she identifies that there is mortality rate high, and she tried to think why the infection high in the hospital. She detected certain reason for the infection, like ventilation was not good, overcrowding of the patient in the same room. So now she identified what is the problem. So she put some changes like improvement of the ventilation in the hospital, follow the standard of hygiene in the hospital, all this, and she is recording. In the same times, she is recording what she is doing. This is lead to decrease the mortality rate in the hospital from 40 to 2% only. So this is really a great achievement for this girl. She is a nurse, but she gave a very excellent reputation about nurses, especially if they like their work. She is known as the Lady of Lamb because at the night she is making ground in the shoulders, and she is using white while she is lamb while she is looking into the shoulders. This is one of the first clinical audit in the world. This is just the story and how importance of the audit could improve the patient care in the hospital. There is problem, I think, in the quiet. Okay. So what is the idea? Okay, serious voice now. Okay. So what is the idea? The idea of audit, this is quality improvement process. Quality improvement process. What is the aim of this quality improvement process? You need to improve patient care. You will improve patient care through systemic review of the care in your department or in your hospital. And you will compare this practice with the standard. Standard, what is the standard? The standards will be Green Top guideline and NICE guideline. So if we see that the shoulder dystocia, how much in our department, so where we will look to the incidence, we will look to the Green Top guideline. So if there is a changes in the hospital, like increase the rate of cesarean section than the standard, we need to know why. We need to investigate. So if we compare with the standard, the rate of the cesarean section is very high in the department, so we need to know what is the reason. We compare our performance in the hospital with the standard, it's high, so we need to know what is the reason for this. We will conduct audit and we will know the reason and we will watch certain changes again and we will re-audit again. So the idea, the first point in the audit, select the topic, and you can't do audit for all the topic. Like you have cesarean section, you can have audit for frequent criteria, like within how much time you are giving antibiotic for the patient, thrombosis post cesarean section, wound infection. You can't do audit for all. Just you will select certain criteria and you will do audit for it. So the first point, select a topic like cesarean section. What criteria, which criteria you want to do audit. Standard, you will review the standard regarding this topic. The standard will be the guidelines, like Green Top guidelines, like also NICE guideline. You will collect information regarding this topic, and you will see what is the changes we can do to improve the care of the patient, and you will do recommendation. And after this, you need to do re-audit again to see if there is improvement or not. How, again, every point from this we will again discuss in simple way. So we need to select the topic, and when you select the topic with high rate of mortality and morbidity and could cause disability. Don't choose topic in your department something rarely occur. So you will choose something common health, and also you will choose something there is evidence. Not logic, there is something we don't have evidence about this. So choose topic, important topic, common health problem with high mortality and morbidity or disability, and also should be there is good research evidence available, so we can compare, because how we will compare if there is no evidence? After we select the topic, we will put certain criteria, because we can't do audit for the whole topic. We can't do, so we need to select certain criteria, like cesarean section rate. Right, the topic will be smoking, hypertension, and we need to do the criteria effect of smoking on the hypertension. So we select certain points, criteria regarding the topic. So what could be the standard? The standard will be the evidence-based, like it will be a number, like should be the cesarean section rate not more than 25%. In our department, it's reached 40. So there is here something affecting the patient morbidity or even mortality, can increase the mortality rate of the patient. Then you need to do data collection. How I will do data collection? Data collection, it will be retrospective or prospective. You will choose either prospective, retrospective, or prospective. Retrospective, you are already today, you wanted to do audit for all the patients in the past. Like I will do audit for the last 6 months. All the patients, they will have cesarean section in the last. So already you have the file available in the hospital. Either in the file or computer, you can access easily. So all the file is there. What is the advantage of this data collection? This is quicker because already all the files is there, so you can collect all data you want. Low cost because the time will be shorter, easier and less time. And disadvantage, when you are looking into the data, maybe there is some missed information important for the audit not mentioned there. Other way of data collection in the future, prospective. Today I will start to do audit. I will look to all the patients would have cesarean section in the future. From today, until 6 months, I will do collection of all the patient data who will have cesarean section, for example. Advantage, I will be taking all the data I want, so I will avoid missed data. Disadvantage, still you need to wait whole 6 months until you finish collection of all the data, so this is time consuming. Also, all the department team, either doctors, nurses, they are aware that there is audit. You are conducting audit, so this will affect the audit by Hawthorne effect. Hawthorne effect, the department, the staff in the department, they will improve their performance. Improvement in the performance, why? Because they know that they are being observed. So the improvement because they are worried from you, because worried from the audit. So this can affect the audit and give false result. So Hawthorne effect, this is improvement in the practice because they are aware that audit is conducted and they are being observed. What you need to collect? For example, we are talking about cesarean section rate high in the department. So we need to collect much data, not only the numbers and no. We could need much information like cesarean section was elective cesarean, was emergency cesarean, and if it is emergency cesarean section, this is what was the indication, how many centimeter patient was, maybe she's fully dilated, she's early in labor 2 centimeter or 3 centimeter, how many centimeter was the patient? If the patient fully dilated, any trial for instrument delivery or instrument delivery was tried and failed. If the patient refused, maybe there is any contraindication for the instrument, like something for the patient severe thrombocytopenia and we can't apply instrument delivery. So some data could be needed. So the one collecting the audit should be someone familiar what could be the data, help to answer the questions needed in the audit. If the hospitals, they have their own team, some hospitals, they have audit team already. But if there is no team available in the hospital, so midwife or doctors, they can also collect the data. Who collecting the data should be aware about the law of Caldecott principles. This is patient confidentiality, because if you opening the patient file, you can approach the patient information, so you should know the law. The law, you need to justify the purpose why you open the patient information and login. You should not use any identified information regarding the patient unless it's absolutely necessary. Try to minimize necessary patient identification informations. Access the patient identification information in strict need. Everybody should be aware about their responsibility and understand and comply to the law. After you collecting all the informations, because this will be huge informations, you need to analyze this informations, and you can use simple statistics, like you are putting in columns, charts, so it will be easy. Just when you see one paper, you can read much information regarding the audit. After this, you will compare the department performance against the standard. You will look what is the difference. We are why much higher than the standard. So there is any recommendation you can do or not. Like when you are doing, you noted that there is much patient conducted emergency cesarean section at fully dilated, and because the staff who conducted this delivery, they are not aware to do forceps or ventouse, so they do cesarean section for the patient because they are not training well in the instrument. So the recommendation here, we need to do training for the doctors more to know how to apply the tools or forceps, so this will decrease the cesarean section at fully dilated patient. After this, we are going to distribute the result. We will not blame persons. This is the aim, the patient. We don't want to do personal blames. Try to be hard on the issue and soft in the individual. You will spread the recommendation either through audit meeting or hospital emails or letters. Sometimes if it is audit in a large hospital, it can be in also quality improvement journal. After this, the recommendation you will do should be the doctors and the nurses aware about the recommendation. And after this, you need to check if they are following this recommendation or no. So you will give again another time, like for 6 months, do audit. You will give them a chances for 6 months, for example, and again you will check the performance and do re-audit again to check if there is improvement in the performance or not. This is in simple the audit. We will start. We need one. We'll start now the questions. No? Who wanted to start?
Ma'am, may I?
It should be sufficient time, at least 6 months, sufficient period if you will do prospective. Retrospective, according to the availability of the staff, because already the files is there. Okay, but for re-audit, you should give at least 6 months. Who will start? Who will start? Who will start? No one? I will start. I can start. I can start, but I don't have exam. No one willing to start? Who's talking?
Can I do it, Dr. Ada?
Dr. Ozma?
Yeah.
Dr. Ozma? Okay, Dr. Ozma. Everyone will take 10 questions. We will start.
Ma'am, may I?
Let him do. No problem. Dinesh. Okay.
Who? Dr. Dinesh? Dr. Dinesh wanted to start? Who's talking? Hello?
I don't know. He said he wants to do it.
Both of you, any one of you, and next will be the second one. Anyone ready?
Okay.
He can start.
Okay, doctor. I'll start.
Okay, send Dr. Dinesh, prepare yourself after her. Okay? Start.
Yeah. A group of doctors are auditing a decision delivery interval according to the hospital protocols. Data were collected and the results were announced on meetings, and a member was dedicated to compare against NICE and RCOG guidelines. Next audit is planned after 6 months. So this is a prospective. Okay. What is missing in the audit cycle? So a group of doctors are there. They have chosen a topic actually. Auditing is decision delivery interval. Data was actually collected. Results were announced, and a member was dedicated to compare this with the standard. So what was missing? Criteria was there. Setting the standard was there. Spreading the results also was there. Did you implement the changes? I mean, is it implement changes and recommendations?
You are asking me or what?
Yeah, I'm just thinking about it.
This
Yes.
this is not an option in the exam.
Okay. And what is missing in the this thing and this cycle? And closing the audit cycle. So what is missing in this cycle? In this cycle of audit, a group of doctors are auditing. Data was collected, results were announced, a member was dedicated, RC standard was set. Next audit is planned after 6 months. What is missing in the audit cycle? Criteria, I don't think it's criteria. Setting the standard, spreading the results, implement changes and recommendations, and closing the audit cycle. Was it they did not close the cycle, audit cycle, Dr. Gada? I'm not getting this properly.
Okay, so what you will choose in the exam?
I thought they have taken a criteria. They have set the standard, RCOG guidelines. They have also collected the data, and the results were also announced. What results were there? They have spread the results. They have implemented changes. I cannot see where they have implemented the changes.
So what is you will choose?
So I would choose implement
It should be.
Yeah, that's what. That's the first one I chose.
Okay, correct. But the point in the exam, be careful. Be careful. You take much time in the exam. It's 103 hours. So be careful. If you see one question will take much time in the exam, you can even in the computer, you can leave and you can return back. Don't worry. You can return back even in the computer and you can solve the question again. So don't be, if there is one question will waste your time, be careful from the time management in the exam. There is no recommendations. They didn't put recommendation. What will be the recommendation? This is correct.
What will be okay. Dr. Gada, can I ask you one question? Just personal one. You know, you have, when you were giving exam, how much of time did you take for a EMQ and how much of time did you take for a SBA to solve? You know, we need to set a time limit because sometimes we are giving a lot of time to one EMQ and very less time we get for another EMQ. So what is the standard? Is it 3 minutes for EMQ or 2 minutes for EMQ?
There is a clock in front you in the exam. For me, I start with single best answer. I took 50 minutes. 50 minutes and the remaining of the time of AMQ, every time I'm watching the clock in front me to do time management. 50 minutes for the single best answer, more than enough. And you start by single best answer because this will be easy and the quicker you can finish. And the AMQ you give time because this will need concentration much, because there will be some tricks in between the questions, so you should concentrate and give much time for the AMQ.
This is exactly debated most of the time, that should you do the SBA first or the EMQ first. But many people, like, I mean, I heard from you that it is SBA first, and I heard from some that it is EMQ first. But yes, I think SBA is better.
I will go with the same what is the examiner put. They are putting the single best answer first, then AMQ. So I will follow the same in the exam. The exam, they are putting the single best answer first, then AMQ. I follow the same what is in the exam. I finish single best answer, and after this, I start AMQ.
Excellent. Thank you. Excellent. Yeah. Okay.
Okay, we can continue. We will avoid questions, so they will concentrate. They will not lose the concentration. Okay, continue, Dr. Uzma.
Yeah. I go along with this.
Yes.
Yeah. Okay. The second one is the unit is studying on suture materials and want to compare against to the RCOG standards. Our unit is studying suture materials and wants to compare against to RCOG standards. So unit known as the patient safety, patient focus, communication table. A unit is studying, what is it? Is it the parliamentary and health service?
Okay, tell me what you will choose. B?
Yeah.
Okay, next.
Next, literature review, what type of study? Literature review, what type of study? It's research,
System.
or it could be systematic review. Systematic review.
Systematic review. Okay, so you
Yeah.
will choose it. Okay, next.
Yeah. Literature review, what type of study? Could be systematic review. Systematic view. The way to find what is best practice. Clinical audit. Clinical audit. The way to find what is best practice. Clinical audit. And fifth one, a quality improvement process that seeks to improve the patient care and outcomes through systematic review of care against explicit criteria and implementation of change. A quality improvement process that seeks to improve the patient care and outcomes through systematic review of care against. I think this is
Audit.
this is I think audit. This quality improvement process
Audit,
that seeks
okay.
to improve patient. This is audit. I think this is audit.
Okay.
And find what is best practice is what is the best practice? Is it the clinical effectiveness?
Okay, choose one. Choose one.
I'm
You
not.
choose one.
I'm not very good in statistics. Yeah, that's exactly what I thought. Or the way to find what is best practice.
Best practice, I will tell you. The first one, audit. When you are comparing something by the standard, will be audit. The first one. Second one, look to literature review. This is when you are wanted to see something in the, you will be systemic reviews like Green Top guideline. I wanted to read about shoulder dystocia. I wanted to know systemic review, so I will look to the literature review. Will be systemic review. This is like Green Top guideline. The best way for practice, this is research. I will do only one answer this one correct. I think his name on the chat BC. This is the only one answer the question correct. Research. If the difference between research and audit research, you wanted to see what is the best practice. You do research, which one will be the best? But when you are compared, when you will ensure that we are follow this best practice, this will be audit. Okay, clear?
Audit, yes. Yes,
and the last one is the definition. This is the last one definition of the clinical audit. If there is something audit. you are comparing
yes,
the
yes. That was the definition of clinical audit. Yes, definitely.
Against you are comparing something by the standards. This is audit. If you're searching for the best, this is research because I wanted to know what is the best. Okay, next.
Okay. Hospital is questioning about a year supply of fibronectin assay kit, which was finished after 6 months only. Hospital is questioning about 1 year supply of fibronectin assay kit that was finished after 6 months only. Incidence report, never event, clinical audit, systemic review. Is it it's not an incident report. Clinical audit, no. Systematic review. Is it a never event?
Never event? No, this is audit. You will do audit. Incidence report. Sometimes they are putting incidence report. Incidence report. If you have one patient, you deliver her and she has 4th degree perineal tear, you will do audit. You will do incidence report because you wanted to investigate what happened for this patient. One patient during a cesarean section, she lost more than 1,500. So you wanted to investigate what happened in this patient. But in audit, you need here to conduct several files, all patient preterm. So you need to do audit. Okay. Next.
Okay, thank you.
Okay, so we will start group B, streptococcal infection and pregnancy. I think this is very easy task, but I
thank you
some
very much,
questions.
Dr.
You continue. You could take 10 questions till you have 3.
Okay, fine. The commonest organism causes early neonatal infection is Streptococcus agalactiae.
Correct. This is group B, streptococcal. Yes. If asking about sepsis in woman, in adult woman, so this will be group A. If he asks about baby, it will be B. Sometimes they are putting B and A. So you choose B for the baby. B for the baby. Okay. Group B, streptococcal agalactiae. This is mean the infection of the neonate. We are discussing a patient, baby with infection less than 7 days. The early infection, the early onset of the infection.
The incidence of early onset GBS, this is in UK and Ireland. It is 0.5 per thousand.
Yes, this is the
B.
background. Yes, this is the background risk. This is the background risk. This is will be highest. The risk of infection will be highest in Black African and lowest in South Asia.
Okay.
I just connect some important numbers. I know it's difficult. We are not a computer, but sometimes in the exams you will put a question regarding the numbers. I want even one question to pass. Just I'm collecting it every two similar. I put in one in the same column, so it will be easy for you. If he asks about the background risk, it will be 0.5. If you want to remember easy, per thousand. If he asks with the patient with pyrexia, it will be 5 per thousand. So 0.5 background, 5 per thousand in the pyrexia. So it's easy. If he put for you one patient, she is carrier in previous pregnancy, we are talking about patient, she not receive any antibiotic, she not receive any treatment. So how much is the risk, the incidence for her? If the patient, she has previous pregnancy, she is carrier, or the patient herself, she has one baby affected with previous baby, the incidence will be similar. 1 every 700 or 1 every 800. So make it with each other so you can remember easily. So the carrier in the previous pregnancy, or the patient, she has one baby affected in the previous pregnancy, the risk of her baby to have again baby infected, it will be 1 every 700. If this patient, she is term without risk factors, or the swab is negative in current pregnancy, so it will be similar incidence. You get the idea? So this 1.2 per thousand and this 1.2 per thousand. I just make it with each other. You get the idea or no? It's clear. So if he asks only about this one, it will be 0.1, 0.2 per thousand. If he asks about this one only, it will be 0.2 per thousand. Just to make it simple for you. If he give you one patient, if she is group B streptococcal positive in current pregnancy, how much percent the baby will be infected? It will be 2.3 per thousand. If he asks you about patient preterm deliver in current pregnancy, how much is the risk? It will be similar, 2.3. So what is the idea? I collect the similar incidence with each other. So in the exam, it will be easy. So 5 every 1,000 if the patient has pyrexia. Background risk 0.5 per thousand, so it's easy. If the patient carrier in the previous pregnancy, or the patient herself, she has baby infected in previous pregnancy, so it will be similar also 1 every 700 per 1 or 1 every 800. If this patient term without risk factor or the swab negative, it will be 0.2 per thousand. Or if the baby preterm or the swab is positive, it will be 2.3 per thousand. So now you save how many numbers? 1, 2, 3, 4, 5. 5. So it's better 5 than 10, and in the end you will be confused. This is group B streptococcal infection is very high in the preterm, and the mortality rate is very high. So if one baby infected with group B streptococcal preterm, how much chance this baby will die? 30%. And if this baby term, only mortality rate will be 3%. So it's much higher in the preterm. So if you have in your department one baby group B streptococcal and the preterm, you will talk to yourself. As we tell before, you talk to yourself because you wanted to pass the exam. So you will tell this baby chance to die about 30%. But if this baby term, you will tell no problem because the mortality rate only it will be 3%. So it will be higher. So this is, they are telling any patient confirmed that she is in labor, you will give her regardless the group B streptococcal, because 1/3 of this babies will die if they will develop group B streptococcal infection. So any baby preterm in labor, confirmed in labor, give intrapartum antibiotic prophylaxis. But if this baby preterm and this baby for cesarean section and the membrane intact, you will not give. You are giving only for cesarean section antibiotic but for group B streptococcal, as the baby, this baby will not deliver vaginally, so no need for giving him as a patient antibiotic during delivery. Next, Dr. Uzma.
Yes, doctor. Yeah. Pregnant women at 35 weeks, swab showed that she is B positive, and how much chance this patient will be negative at the time of delivery. Okay.
You are now in the clinic. One patient, she comes to you and already positive. She tell you, doctor, how much chance I will have negative swab at delivery? You should answer, and you should use this point is when you are talking to your patient in the clinic. You will tell her there is a chance that you will have positive in pregnancy. How much?
It could be 25. Is it 25?
So it's 25, 17 to 25, so 1/4.
17 to 25. Yes.
1/4 of the patient. So when you are counseling one patient in the clinic, tell her, the swab will be, you are now positive, but there is chance that you will be negative in about 1/4 of the patient. About 1/4. I make it an easy way because it's difficult to remember 17 to 25, so make it easy. It's 1/4 of the patients they will be negative at time of delivery.
And I have another doubt, Dr. Ghata. I just wanted to ask you, there is a range.
Dr. Uzma, please just write, any one of you, not only Dr. Uzma, any one of you have one question, just write it in small papers, and in the end we will open discussion, because others you will lose interest. Okay, we need all to concentrate well in the questions. Okay.
Okay, doctor. Okay, doctor.
Okay, continue.
Yes.
You can see the question.
Yeah, it's Dr. the same Osman. Question. It's the same question.
No,
pregnant women at 35 weeks show that she is group B negative, and how much chance this patient will be positive at the time of delivery? 35 shows she's negative. So how much chance this patient will be positive? It's A. I think it's only 5%, I think.
So if you have one patient now in the clinic and the hair swab negative, you will tell her there is a chance about 5 to 7%, 5% almost, you will have again infection at the time of the delivery. If you use this one in your daily life, it will be easy to remember. Okay, thank you, Dr. Uzma.
Thank you very much, Dr. Khada. Thank you very much for giving me this opportunity. Thank you very much.
Thank you, Dr. Uzma. This is why universal bacteriological screening for group B streptococcal not recommended. This is a question in OSCE exam. If one will go for OSCE exam, this could be a question. It is recommended to do screening for group B streptococcal infection for all the women pregnant? No. So why? The next question he will ask you why. Because there is no clear evidence that screening would do more good than harm. We just now talking about that could be one patient positive at the time of screening and again negative. So it's not 100% it's accurate. And this is only will not expect. This is will not expect which baby will be very sick. And even some babies delivered preterm before the time of screening. This is another thing. So the time of screening at 35 to 37, this baby delivered at preterm. And the mortality rate will be very high in the preterm. So this is before the time of screening. And if you will do screening for all the women, this will mean that all of the women, they will take antibiotics. This means huge number of the women, they will receive antibiotic. And this can increase the adverse effect outcome to the mother and the boys. The second question, and this is very important, who will receive antibiotic prophylaxis during delivery? This is very important. Concentrate well, because this is the most important point in the exam. He will give you scenario and he will ask you, you will give or no. This is very important to concentrate from here well, because this will be a question in the exam. So if you have one patient, she tell you, I have one baby affected in previous pregnancy by group B streptococcal infection. Be careful here. We are talking about early infection in this guideline, but in this point, especially if the mother, she either give you in the exam early or late infection by group B streptococcal infection, you will give. So the guideline, we are talking only about early infection less than 7 days. But if the patient, she tell you, doctor, my baby, previous baby, he has affected by this infection, either early or late, this patient she will take during labor. Second one, if she is carrier in current pregnancy, she has a swab during pregnancy, in any time in the pregnancy, she has infection in her urine, or she has vaginal infection by group B streptococcal, also this patient, she will take antibiotic during labor. If baby preterm, so any preterm, don't forget that this baby, regardless group B streptococcal negative or positive, you will give. Be careful, preterm only indication, be careful. Prolonged rupture of membrane more than 18 hours is also risk factor. This patient we need also prophylactic antibiotic. This patient suspected chorioamnitis or pyrexia. This is the indication you will give. This patient will be at risk of having group B streptococcal infection in her baby. We will start. Dr. Danish, you can share. Dr. Danish. Hello.
Ma'am, can I volunteer
Yes,
if he is
ma'am.
not there?
Dr. Danish first, then you, Dr. Ankita. Dr. Danish first.
Okay, ma'am.
Dr. Danish.
To para 1, pregnant patient 16 weeks, first baby is affected by GBS. If first baby is affected by GBS, then there is a need of intrapartum. There is a need of intrapartum antibiotic prophylaxis.
Okay, so your answer?
A.
Correct. Next.
Patient came in the antenatal clinic. Her friend has a GBS in pregnancy. Her baby died after delivery. She wants her risk of having GBS is like 0.57 per 1,000 population as a routine general risk. That is B.
Okay, B. Next.
What is the risk of recurrence in another pregnancy if GBS carrier in the last pregnancy? In the next pregnancy, if the previous pregnancy with GBS carrier is it's 2.3 per 1,000. Option A.
So A.
Yeah. What is the incidence of GBS affect baby if patient? एक minute, ma'am. Can't see. Patient untreated. It's no, it's 1 in 700.
1 in 700. Okay, let's see your answer. E. Okay. So the first one, she talking about in the exam, some they are not concentrate. Once CZ, one baby died, so they are confused. She is talking about her friend, not herself. So be careful when you are reading the question. So she asking about herself. So she asking about the background risk. Excellent. It will be 0.5 per 1,000. Asking about one patient, she has group B streptococcal in carrier in previous pregnancy. How much risk for her? Carrier again. She will be carrier again in 50%. The patient she will be carrier again. He is talking about the patient, not the baby here. So the risk of recurrence again that she is carrier, it will be 50% one and two. What is the incidence if she is not treated? He is talking about carrier, one patient carrier. Just now in the, if you remember, we are putting if one patient carrier, she didn't receive the risk, it will be 1 every 700 or 1 every 800. So only one question wrong. Okay, next. You can see the question, Dr. Danish.
Yes, ma'am. Patient woman 10 weeks. She has history of GBS carrier in the last pregnancy. What will be the plan for current pregnancy? Screening of GBS at 35 weeks and regardless of the result of intrapartum antibiotic prophylaxis should be offered. C.
So you will choose C.
Yes, ma'am.
So A. If you have one patient carrier, you have either two plans. Either you will give her immediately intrapartum prophylaxis without screening, if she would like, no problem, because 50% she will be carrier. Or she tell you, doctor, no, I wanted to have a screening, so you will screen, but you will give only if she is positive. You get the idea. Again, you look again to the options. He mentioned offer antibiotic without screening. Yes, this is option. This is kind of option, correct? According to the guideline, I can't offer her. But if I will give screening, this is another option. Okay, but I will give her only if she is positive, not regardless. Regardless mean
Oh.
negative or positive, but in the guideline he mentioned if only positive, if she screened. So what is the option for the patient carrier? You have one patient now in antenatal care carrier. You have two options. Either you will take antibiotic during the delivery, if you would like, or we can do screening for you. And if it is positive, we will give what you will choose. So in the end, she will choose either this or this. So be careful before you answer. The risk will be here twofold more than the general population for the patient carrier. I just put it in this way to make it. I want you to be confused. Don't worry, because this will make you remember well what is written in the guideline. Okay?
Yes, ma'am. Gravida to Paravan 10 weeks. Gravida to Paravan 10 weeks twin has a history of GBS carried in previous pregnancy when screening of GBS should be at 35 weeks, ma'am.
At 35 weeks, but she is twins. So in the exam, I choose 35 because I know the screening at 35 to 36, but here she is twins. And in the guideline, they mention if there is risk of this baby, this one screening will be at 35 to 37. But if you anticipate the delivery early, it should be 5 weeks early. So like in twins, it should be at 32 weeks. Another trick. Why? Because sometimes you know the information, but in the exam, you should concentrate well. This baby term, so your answer will be correct. Usually single baby, 35 to 37, but at twins, it will be more early. So it's better at 32 to 34. Clear? Clear or no?
Yes, ma'am.
I just put it in this way to make you concentrate well in the guideline and in the question.
Pregnant patient 35 weeks diagnosed with GBS disease in vaginal culture. So it's need of intrapartum antibiotic prophylaxis. Yeah, it's option A, ma'am.
A, because it's in the vagina, so we are giving intrapartum prophylaxis antibiotic. Correct. So this patient, the previous question we are talking about when you will do screen, it will be if the patient at term, no risk of preterm, you will screen at 35 to 37. Okay. But if this patient at risk to deliver early, like twins pregnancy, so make the screening early. So it will be at 32 to 34. This is the idea from the question. This question, if the patient she has vaginal swab positive, you will offer only intrapartum. No need to treat the patient right now. How you will take the swab? Either you will take the swab from the vagina or another swab from the anorectal, so you can take swabs. In the hospital, usually you need to use only one. This will decrease the cost better, but in the guidelines, they put both options. Both options they can use. But for your daily practice, you can take from the lower vagina and then from anorectal in one swab, and you can send, because we want to identify this patient carrier for group B streptococcal or no, and this will be sent to non-nutrient transport media. So it can be either two swabs, one from the lower vagina and another one from the anorectal, or one swab you will start first by lower vagina, then anorectal in one swab. It can be.
A pregnant patient 16 weeks diagnosed with GBS disease in urine culture, growth is 10⁴. Urine culture. Again, she will need the intrapartum antibiotic prophylaxis.
Why not B?
Ma'am, for asymptomatic bacteriuria is 10⁵. It should be 10⁵, more than 10⁵.
Excellent, excellent. Power up should be 5. Very excellent, very excellent. Why? Because it's the guideline. If you see the number up 5, so it's 100,000. So if it is only about the power above, it's 4 only. So this patient will need only intrapartum. You will treat the patient only from bacteriuria if you see the above number 5. Be careful. Here's the number what? The above number how much? It's only 4. Some they are thinking only bacteriuria. then you will go run and use, because it's in urine, you will treat now and treat during labor. Be careful how much bacteriuria. So you will see the number raise the 10. It's 5, so you can use now and later an intrapartum. But it is 4, so this patient only need intrapartum antibiotic. Excellent. So now this is just also another tricky question. Okay, this is one, another one.
Pregnant patient, 16 weeks, diagnosed with GBS, urine culture growth greater than 10 days. Right now, she will need the antibiotics now and intrapartum antibiotic prophylaxis. Option B.
Yes, because he put here, you see the above number, it's 5, so it's 100,000. So this patient will need it treated now, and you will give also during labor. Excellent. So be careful before answering the question. Be careful. Okay, next.
Pregnant para 3 previous 3 section patient 37 weeks diagnosed with GBS disease in vaginal culture at 36 weeks, planned section at 39 weeks. If it is with intact membrane, as it is a planned section, there is no need of intrapartum antibiotic prophylaxis.
So no need for antibiotic because this patient for cesarean section. In the exam, he will not tell you, take care. This patient for cesarean section, under the stress of the exam, this question will come in between. Oh, this is a group B streptococcal. I will give her antibiotic. And this patient for cesarean section, they are giving them broad spectrum antibiotic according to the NICE guideline. But for group B streptococcal infection, they will not give. But if the patient, she has rupture membrane, you will give her antibiotic against group B streptococcal, and you will see which category you will do for this patient, either category 2 or category 3, because category 1 will be within 30 minutes, so no need, because already this patient will be for cesarean section within 30 minutes. Thank you, Dr. Danish, for sharing. Thanks a lot
Thanks
for you.
a lot, ma'am.
We can take Dr. Ankita. Dr. Ankita is the one talking, or who?
Yes,
Dr.
ma'am.
Ankita.
I'm here, ma'am.
Okay.
Yes, ma'am. Should I read this question, ma'am?
Yes.
Pregnant woman, she is para 3 with previous 3 vaginal delivery. Vaginal swab at 36 weeks, diagnosed with GBS disease. Today she is pregnant, 38 weeks, presented with labor pains. Cervix is 3 centimeter cephalic. IUFD confirmed by ultrasound, as there is IUFD. So there is no need of intrapartum antibiotic now. No, I will go with C, ma'am, because we give
Yes.
GBS prophylaxis for baby.
For
C.
baby. So baby already died. So be careful. Be
Yes,
careful.
ma'am.
This is could be now we are sitting, we are relaxed, we have our coffee, we can no. But in the exam, from the stress, generally swab positive, and you will run and you will choose antibiotic. No, this baby already died, so no need to give prophylaxis against group B streptococcal. Next.
Priming gravida at 39 weeks with pyrexia during labor. Start IPA now. No need for antibiotic. Start broad spectrum antibiotic, including cover for GBS. Ma'am, I'll go with C because the patient is having pyrexia. So we will think of other infections also along with GBS. I'll go with C.
So pyrexia. So which antibiotic you will give to her?
Ma'am, Gentaclinda should be given, I guess.
Gentaclinda. What is about to the
And
guideline?
along with the GBS prophylaxis, ma'am.
No, in broad spectrum antibiotic in the especially in the pyrexia and chorioamnitis, you will give broad spectrum antibiotic in the guidelines they mention IV amoxicillin 2 gram every 6 hours and or IV cefuroxime 1.5 gram every 6 hours. Be careful. So when the patient has pyrexia and chorioamnitis, we are giving every 6 hours, because in the exam he will put about 20 options, 6 hours, 4 hours, 3 hours, 2 hours, and you are which one I will choose. So he will want to make you confused. So in the patient broad spectrum, you are just, it's broad spectrum. So I will give every 6, because the penicillin, we'll talk about the penicillin later, it will be every 4. So every Q6 hours, every 6 hours, it will be intravenous amoxicillin 2 gram, Q6 hours, or cefuroxime 1.5 gram every 6 hours. This is for 2 cases, pyrexia and chorioamnionitis. Okay, next.
Okay, ma'am. Primary gravida at 33 weeks with confirmed preterm labor pains. Start IPA now. Yes, it could be the option. Start IPA when cervix is 4 centimeter. No. No need for antibiotic. No. Start broad spectrum antibiotic. Why to start? Ma'am, I'll go with A.
You will go with A. Why? Because all preterm. How much mortality? How much mortality we mention if the baby affected?
30 to 50% or 10 to 30%.
30, 1/3 of the baby. 1/3 of the baby.
20 to
But if
30.
1/3. So
30%.
if you
I
are
just remember the 30.
30% in term, 3%, 30% in preterm, 3%
Preterm,
only in
3%
term.
in term.
And if this baby preterm, you are deliver this baby with cesarean section, so no need. Be careful. If you are going to deliver cesarean section, already the patient she will receive broad spectrum and the membrane intact, no need to give her antibiotic. Okay, so if you have one patient preterm with rupture membrane, the problem we need to mute mics, please mute your mic. Okay, the point here. All the group, it will be difficult and wasting much time also. Okay, so the point here, we will continue to the point if patient come with rupture membrane. If rupture membrane less than 34, so if you deliver one baby before 34, this is also increase the risk of morbidity and mortality of the baby. So just even group with streptococcal, just you need to follow the NICE guideline and you will give this patient erythromycin 250 milligram 4 times a day for maximum 10 days. And when this patient develop labor pain, or after 34, you can deliver her. Once she start labor pain, you can give again prophylaxis against group B streptococcal as a preterm. I think is the voice clear. What is also, if the patient can't tolerate erythromycin, you can give her oral penicillin. But if this patient from 34 to 36 weeks and rupture membrane and she has also group B streptococcal, so no need to wait. It's preferred when they compare both, you are waiting or you are going to give induction, both the same outcome. So it's preferred to do induction for this patient, and once she start labor pain, you will start to give her antibiotic prophylaxis against group B streptococcal. So if less than 34 weeks rupture membrane, pre-labor rupture membrane, you will give her according to NICE guideline erythromycin 250 milligram 4 times 10 days. If she can't tolerate, you can give oral penicillin. If this patient from 34 to 36 and she has group B streptococcal, it's preferred to do induction. And once she starts labor pain, you will start prophylactic antibiotic. Prophylactic antibiotic. Next. Dr. Ankita, because I mute all the mics.
Yes, ma'am. Sorry, ma'am. Primary gravida at 37 weeks with PROM. She is not known if she is GBS carrier or no. Primary gravida 37 weeks and she is PROM, premature rupture of membrane. And is not known if she is GBS carrier or no. Start IPA now. No. Start IPA when the cervix is 4 centimeter dilatation. No, she is term. No need of antibiotic. Start broad spectrum antibiotic. I'll go with C, ma'am. If the rupture will be more than 18 hours, then we will start. I'll go with C.
Yes, if patient not knowing she is term and not knowing that she has group B streptococcal, no problem. No problem. You can just follow, either you will do waiting for 24 hours and induction or immediate induction, whatever it can be. But if it is unknown and term, no need to give. But if it is unknown and in preterm, give all. Make it as a rule. In preterm, give all. If term and unknown, don't give. Don't give. Okay, because we tell just now that if infection occurs, 3% only mortality, so it's very low, and maybe also this patient even she don't have the infection, so no need to give the patient rupture membrane at term if unknown group B streptococcal. No need. Just if you follow this one in your department, it will be easy for you to remember.
So, ma'am, if the patient is known positive and she is term rupture of membrane, with even if she is not in labor, we should start, or we will start in labor only.
In labor, when you are
Labor
giving
only.
only the prophylaxis once the patient she is in labor. Even we are talking about preterm, when we will do induction for the baby, induction for delivery of the baby, we will give once the patient start labor pain.
So we are inducing, then we will not give. We will give only when she comes in active labor, or we should give along with
Yes.
induction.
No. If once you can start induction, maybe she will take time until she start labor pain. But in the guideline, it's mentioned clearly. You will start once she start labor pain. We will answer when it will be effective the antibiotic also in the next question. In active labor, when she started to have active labor, you will give. Okay, not from the start. Okay, continue.
Oh, okay, ma'am. Thank you, ma'am. Pregnant patient, 37 weeks in labor. She has a history of GBS infection at 16 weeks in urine culture. 1 gram benzyl penicillin be given every 4 hours until delivery. 3 gram benzyl penicillin should be given as soon as possible after the onset of labor, and 1.5 gram per hourly until delivery. I'll go with B. 3 gram IV benzyl penicillin can be given every 4 hourly. Notes high dose. I'll go with B, ma'am. 3 gram loading dose should be given, followed by 1.
Yes, this is the
B.
third question in all cases. They can ask you what is the type of antibiotic you will give to the patient with group B streptococcal infection, and how much the duration and how much the dose. This is important. So you will start first IV penicillin 3 gram. Okay, and this will be after the onset of the labor. You see this point, after the onset of the labor, and after this it will be 1.5 gram for hourly until the delivery. It's better, it will be effective if this patient receive 4 hours before the delivery. And even in some study, even still 2 hours and she can deliver, if she come in active labor, you can give, it can give some protection even if the baby delivered within 2 hours. So give. Whenever possible, you can give if the patient start labor pain. But when will be effective? At least 4 hours prior to the delivery. Again, previous baby affected. If you look to the last two, it will be broad spectrum antibiotic. The first 4, 1, 2, 3, 4, it will be penicillin, and the last two, and we mentioned it will be Q6 hours, the broad spectrum, and we mentioned the penicillin will be every 4 hours. Okay.
Yes, ma'am. Primary gravida at 27 weeks, which she is known she is GBS positive in the current pregnancy. She gives history of vomiting after receiving penicillin, before which antibiotic she should take. Cephalosporin, vancomycin, no need for antibiotic. Penicillin, ma'am, because she is having only vomiting. She doesn't have any allergy with penicillin. So I'll go with D.
So vomiting not is indication for stop the penicillin. In the guideline, they mention,
Yes, ma'am.
if only vomiting patient report that she has vomiting before after penicillin, this is not indication to stop the treatment. So you can give penicillin. Okay, next.
Primary gravida at 37 weeks with she is known she is GBS positive. She has mild allergy to penicillin, before which antibiotic she should take. Cephalosporin, yes. Vanco, severe, no need for antibiotic. Start broad spectrum. I'll go with A, ma'am, because it is mild allergy, so we can give
Mild.
cephalosporin.
Okay, so
Otherwise, we could
vomiting,
have
we can continue on penicillin. Mild, we will give cephalosporin. Excellent.
primary gravida 37 weeks, severe allergy, so I'll go with vancomycin.
Vancomycin.
Yes,
So severe
B.
vancomycin. How I will know that this is patient she has severe? He will tell you this patient she has anaphylaxis, she have angioedema, respiratory distress, and diarrhea. So this will be the severe allergy. So mild, it will be cephalosporin. If severe, I will give vancomycin. If he tell you patient only vomit, be careful. Could be a question in the exam. You will give the patient penicillin. How much penicillin? 3 gram initial dose. After this, 1.5 every 4 hours until the delivery. Okay, next. If this is not a question, baby with clinical, suppose this baby delivered and he have already clinical signs of the infection, they will treat this baby. Usually the one will come in the exam, usually it will be even in OSCE exams, you will ask regarding the antibiotic for the woman. But for the baby, usually this will be the work of the pediatrician. But they are, just for the knowledge, they are treating the baby with penicillin and gentamicin, and the treatment should be started within 1 hour of decision of the treatment. So they decide to treat this baby should receive the antibiotic within 1 hour. If term babies who are clinically well at birth and whom mother receive already intrapartum antibiotic, this patient, if they are taking the antibiotic more than 4 hours before the delivery, no need special observation. Suppose this patient woman, she is carrier, and you give her antibiotic during labor, and this antibiotic started 4 hours before the delivery. So this baby needed to be observed, no need to be observed. The other one, babies for women who receive broad spectrum antibiotic during labor for other indications other than group B streptococcal. For example, you are giving this patient antibiotic for any other reasons other than group B streptococcal. So this baby will need investigation according to the NICE guideline on early onset of neonatal infection. If the other one, if you how should be babies are at risk disease whose mother not receive adequate antibiotic prophylaxis. If you have one baby at risk and there is no antibiotic was given to the patient, so we need to observe this baby at least 12 hours. Why 12 hours? If you look down, because 90% of the infant, 90% will diagnosed within the will have signs of the infection within 12 hours. So if this patient should receive and she didn't receive, how this baby should be observed? He will be observed vital sign at 0, at 1 hour, 2 hours, then every 2 hours until 12 hours. We need to confirm, because 90% of the babies, they will develop the infections within the first 12 hours. Postnatal antibiotic prophylaxis is not recommended for asymptomatic term baby without knowing antenatal care. So don't give prophylactic antibiotic for all the term baby without any risk factors. So it's not recommended as a prophylaxis for the baby. How should be the baby mother who had baby previously affected with group B streptococcal? If this baby there is no any he received antibiotics and everything care given to him, but the mother give history that this baby, he has already baby affected, so it's better to evaluate this baby again at 0 and 1 and 2 and then every 2 hours until the first 12 hours. If she has one baby already affected in previous pregnancy, so it's better to do the same observation. I think if we look to the up, the same observation for the patient who didn't receive antibiotic prophylaxis during labor. But this patient, she has risk factor strong. She has one baby already affected in the first previous pregnancy. She can breastfeed her baby. Yes, she can breastfeed her baby. No any problem and no any contraindication regarding the breastfeed. Some questions patient she can ask you, if I have group B streptococcal, I can have birth pool. Yes. If she is receiving the antibiotic during labor, no problem, she can have birth. What about if she requests, she come to the clinic and she asks you to do screening and there is no any risk factors? It should not be done for her. Sometimes because you refuse in the National Health Service, she can go and she can do in private clinic. So if she bring a result, she tell you, doctor, I do in accreditation laboratory outside. So if you have accreditation accredited laboratory, you can give for her intrapartum also antibiotic during labor, no problem. Method of induction, it will be very according to group B streptococcal infection. No, whatever you want to do, artificial rupture of membrane swabbing, whatever you can do, no problem. There is no any contraindication, and there is no any emergency to do PCR for screening for infection at the onset of the delivery, not recommended. This is just the important questions could appear in the exam in this topic, and this is the source of the information from Green Top Guidelines, September 2017. I think we stop now. We will move to the chickenpox. Chickenpox in pregnancy, this is very important topic. In group-based streptococcal, you can face AMQ, so you can have 3 questions in the exam. In a chickenpox also, you can have also 3 questions in the exam, AMQ. Different scenario, usually it will not come single best. Usually it can be AMQ, but it can be also single best answer. Dr. Ankita, next.
Yes, ma'am. The incubation period is between of chickenpox. The incubation period of chickenpox is in between 1 to 3 weeks, ma'am. I'll go with A. It's 7
1
to
and
21
3
days.
weeks. 1 and 3
Yes, ma'am.
weeks.
A.
So primary chicken varicella zoster virus infection in pregnancy, this is uncommon. It's about 3 every 1,000 in pregnancy. I think all of you see patient pregnant with chickenpox. I think no one impossible to see. Should you see one case at least? So it's about 3 every 1,000. Varicella zoster virus, this is DNA virus. This is how it will be transmitted either by respiratory droplet or direct personal contact with the physical fluids. This can be either by clothing, bedding.
If a woman of reproductive age is vaccinated, she should be advised to avoid pregnancy for 1 month, I guess. No need to avoid pregnancy 4 weeks. Yes, ma'am. I'll go with B. 1 month.
1 month. So if she received
Yes,
vaccination,
ma'am.
so if she received vaccination and she by luck she conceived, she is pregnant now, and
No.
she asked you, doctor, is this vaccination
No, we
affect
should
my
not
baby?
terminate. No, ma'am. It will
You
not
should
affect. If it
terminate.
is inadvertently affected, given during pregnancy, we should not ask her to terminate the pregnancy. We should reassure her.
Yes, we need to reassure her. She should at least 4 weeks. The vaccination, it's about 2 doses. She should avoid pregnancy at least 4 weeks after completing the 2 doses of the vaccine. And after vaccine also, she avoid contact with the pregnant woman. Transmission of the virus, it will be rare of the vaccine because this will be live attenuated vaccine. There is no any case by luck, if this patient she receives this vaccine during the pregnancy, there is no any reported that this could increase the risk of fetal abnormality. So it's even it's happened during a pregnancy, so you should reassure the woman that this will not affect and no need to terminate the pregnancy. Over 90% of the girls above 15 years old, they will be seropositive for varicella zoster virus.
Should I continue with this, ma'am?
Sorry, we will take another one. Okay, thank you, Dr. Ankita.
Yes, ma'am.
Sorry.
That's why.
Thank
Thank you so much,
you.
ma'am. You are doing great,
Thank
ma'am.
you.
Thank you so
Thank
much.
you. Thank you.
Dr.
Another one.
Kada, can I
Who
share?
will share? Yeah, what's your name?
I'm Dr. Sumaya.
Okay, Dr. Sumaya, start. So please, everyone 10. Good, Dr. Ankita. Okay, everyone only 10. Okay, check.
Chickenpox is infectious for 2 days. 2 days before the rash appears. It's B.
2 days before the rash appear, and until when it will be
Until 5 days
infected?
of the crossover.
Crossover. So 2 days before appearance of the rash and the 5 days after appearance until it will be crossed over. It will take about 5 days. This is important. Why? Because you need to ask the patient when she is contact with this child. Usually he will tell you this patient has contact with her son or a child in the school. So you should check in this time the baby infected or no. How I will know? If she is contact with this baby 2 days before the rash or 5 days after rash appear. How much it will be the crusted over of the rash? It will take 5 days. So make it in simple way: 2 days before appearance of the rash and 5 days after appearance of the rash. Okay, next. All right.
It's CMQ.
Yes.
Pregnant women, 19 weeks. She came to ANC. She gave history of contact with the chickenpox person. First, we will take history. if she has any history of chickenpox has got or no. If she can remember or she doesn't remember, we will check blood for serology.
So tell me 32. 32, what is your answer?
B.
What? What? What is your answer? So question number 32, you will choose the check blood for varicella zoster virus IgG?
Pregnant women and history. No, I will take history.
What is the point in the history? What is the point in, so you will choose D. So what is the point in the history you need to ask to this patient?
If she has got any previous history of chickenpox or not.
Okay, good. Any other questions?
And contact, how much significant contact with the chickenpox person?
Okay, how much should be the significant contact?
It should be 15 minutes in a ward, or in a room it may be 5 minutes.
15 minutes what? 15 minutes what?
Word.
15 minutes word?
Face-to-face contact is for 5 minutes.
Face-to-face 5 minutes, okay. Face-to-face 5 minutes, and 15 minutes for what?
Word, in a word.
Okay, so next question. 33.
33, pregnant women, 14 weeks. She came, NC, she gave history, no contact of child with chickenpox yesterday. Patient don't have any history of chickenpox before. This is B. I would check her immunoglobulin.
Okay, so B, check blood for varicella zoster virus IgG. Okay, next, 34.
34, pregnant women, she come for ANC 13 weeks. She give a history of contact her son with chickenpox. Patient is not sure that she give history of chickenpox before or no varicella zoster IgG negative. This is also, I will do B.
You will do what?
I will take serology.
34. You will choose serology again, B?
No, she is negative.
Okay, so why you wanted to check again? It's a given, but in the exam you will do like this. Some you will do like this. You will choose again. It's a given. It's a given in the question. Yeah. Serology done. So what is your action?
I will give immunoglobulin.
Which one? Which one you will choose?
C. It's C.
C. Until how many days this patient she can receive varicella zoster immunoglobulin?
10
how
days.
many?
Within
10 days. Okay, so the first one, if you have one patient, she come and she tell you, I have contact, so you take history. This can come in the exam by this way. 3 questions, every question, certain action, most probably, 99%, they will give different answers. Don't think if you choose the same answer, check again your answer. Most probably 99% there will be different answers. So take history. Take history of what? If she has a chickenpox before, maybe she's immune. She tells you, I have chickenpox. If she tell you, I'm uncertain, she is not sure, so still she is not immune. We don't know. If she confirm in the exam, so she confirm. If she tell I'm in doubt, so we need to confirm. Significant of contact, either 5 minutes face to face or 15 minutes in the wall. The other one, patient already She gave history, she don't have history. Now she is confirming that there is no any history. So we need to check if she is immune or no. So this was correct answer. As the last one, the patient already negative. We have the result, and when the result come, it's negative. If positive, okay, we will reassure her. But if it is negative, we need to give her varicella zoster immunoglobulin.
What if she had got chickenpox before? Like the 34th question.
If she has a chickenpox confirmed, she is immune. So reassure. If she, and most probably if he give you in the exam, this patient she confirmed. She tell, I am sure I have. So this patient immunized. In the first, we tell about 90% of the girls more than 15 years, they are immune because they have the infection before. So if the patient tell you, I am sure, doctor, I have a chickenpox. But in the question, if he tell you, she suspected, she is not sure, he give you something, she is not confirmed. So again, you need to check. Maybe doctor, some patient ask her, you have a chickenpox? Maybe doctor. So this is not confirmation, this is maybe. So she is not confirmed. Okay, so we need to check. Next.
Okay.
This is 35. Pregnant women, 21 weeks. She come for ANC. She gave history of contact to child with chickenpox, and she have rash today all over the body. So she has already developed the rash. We will offer her. No, we will consider. This is less than 24.
So which one you will go?
Here is not considered a cyclovir, so I will go for J, symptomatic treatment.
35. Patient pregnant to 21 weeks come for antenatal care. Chickenpox. She gave history of rash today all over the body. She is not immune to varicella zoster virus. So what is your answer?
Consider.
Have E cyclovir and you have I cyclovir. Please, all of you mute yourself except Dr. Sumaya. Please mute yourself all. Dr. Sumaya, where are you?
Yes, I am here.
Okay, so you need to cyclovir. We have here 2 doses of cyclovir. Number E and the number I. So which one?
I will choose I. It's bigger. 800.
I.
800.
Bigger. Okay, I. Okay, next. I. 35 I. Next.
Next, pregnant women, 15 weeks, give history of
the spelling. If
contact
something
to child.
spelling, forgive me regarding the spelling. Okay. Okay.
Yeah.
Continue.
Chickenpox. She has a rash 2 days previously all over the body. She is 15 weeks. I will give her symptomatic treatment and avoid contact with other pregnant or children. And do ultrasound after birth.
So which one?
J.
Why you don't give her cyclovir as number 35?
It is not given. We consider below from after 24 weeks.
Any other reason you will not give her cyclovir?
And it is if rash is occurred within 24 hours. It's already 48 hours.
Yes, within 24 hours, I will offer cyclovir. After 24 hours, symptomatic treatment. Okay, next, 37.
37, 19 weeks pregnant women come for NC. History of contact to child with chickenpox. She has severe today all of the body. In case of severe IV.
Yes, severe. We have keyword in each. When you are solving any question in the exam, there will be keyword helping you to answer the question. So the keyword here, what?
Severe chickenpox.
severe. So you are going to give this patient IV because already she come in the first day. Cyclovir would be 800 because you are giving, don't be confused between chickenpox and herpes. We mentioned this one before in the record in the group, just to remember easy. Herpes make it weak, chickenpox stronger. So chickenpox will be 800, 5 times per day for 7 days. Herpes simplex weaker, so we are giving only 400, 3 times per day for 5 days. So make it by this way because these questions could appear in the exam and he will give you both, the one for herpes and one for chickenpox, and in the exam you are confused. Remember, chickenpox is stronger, so just it will be higher dose, 800, more frequency, so it will be 5 times per day, and longer duration, so it will be for 7 days. Second one already passed 2 days, so you will give symptomatic treatment and will ask her to avoid contact with pregnant women and children, and she will have also ultrasound after 5 weeks. Whatever, sometimes they are putting only conservative management and other options not there. Sometimes he just give you ultrasound after 5 weeks. Whatever it's there, you can choose. When you choose any answer in the exam, just look again to the other options. Any more options could be more correct. So sometimes maybe it will not be there, this one, symptomatic. It's only expectant management or conservative or just wait, okay? So it's not mentioned the symptomatic treatment. So what I will choose, so according what is given in the options. So be careful, but will be the better option, symptomatic treatment, avoid contact, and ultrasound after 5 weeks. Last one, patient severe. If he give you keyword patient severe, this is patient she will need IV cyclovir. Next.
Dr. Gada, regarding question number 35, please. Sorry to interrupt, ma'am.
Which problem?
Hello?
35? Yes, what is the problem?
35, ma'am.
Yes.
Ma'am, should we give oral acyclovir within 24-hour onset of rash or within 24 hours of exposure?
Onset of rash. Onset.
Okay, ma'am.
We are
Within
not
24
giving,
hours of onset of
we
rash.
are not giving cyclovir only if there is rash. Don't be confused between varicella zoster immunoglobulin. We are giving immunoglobulin only if the patient don't have rash. She has contact, and we are giving only contact up to 10 days. But if she started to have rash, no rule for varicella zoster immunoglobulin. We will start cyclovir. Within 24 hours, we will give cyclovir. After 24 hours, we will do symptomatic treatment. Next, Dr. Sumaya.
Oh, thank you, ma'am.
Dr. Sumaya, next.
Pregnant women 14 weeks come for ANC, give history of contact with child with chickenpox. She starts rash all over the body today. Patient don't have any history of chickenpox before. Here we can consider acyclovir.
Why not H?
Acyclovir is offered from 24 weeks onward.
So you choose, consider, it will be I. 20, not 20 weeks.
Yeah, sorry, 20 weeks. Yeah.
20 weeks. So in the exam, take care from word give and word consider. Consider, you can give or not give. So the cyclovir after 20 weeks or more, you can give cyclovir. Less than 20 weeks, you can consider. It's not licensed cyclovir to use, but there is no any evidence it's caused congenital anomalies for the baby. So you can give cyclovir. If there is option give, so you will look to the gestational age, 20 or more, so give cyclovir. If the patient less than 20 weeks, you will choose word consider. If only cyclovir there, so choose cyclovir. So maybe only he didn't put cyclovir either consider or give. So you can choose cyclovir. If she present 24 hours from appearance of the rash, 24 hours. When we will choose the IV, if the patient she has severe chickenpox. Don't choose varicella zoster immunoglobulin if there is rash. Once rash appear, within 24 hours cyclovir, after 24 hours only symptomatic treatment. And avoid contact. And if the patient in the less than 20 weeks, you can refer her for anomaly scan after 5 weeks or at 16 to 20 weeks. Next.
Pregnant women 14 weeks come for NC. She give history of contact with child or with chickenpox. Patient don't have any history of chickenpox before. You check varicella IgG. Result is negative. You want to give her varicella IgG. IgG is effective up to 10 days.
So you can give 10 days from the contact. So if the patient after 6 days, you can give 7 days. So up to 10 days, you can give the patient. Okay. Remember, we will not give the patient varicella zoster immunoglobulin if she started to have rash. Be careful from this point. Okay, next. This is a chart in the guideline. If you have one patient with varicella zoster contact, he will give you this patient. She come today in antenatal care. She has significant contact with a child with chickenpox, either her son in the school, and he will ask you your action. So if he give you, first point, ask history. If she tell you I have past history of a chickenpox, reassure the patient, no problem, and routine antenatal care. If she tell you I am not sure about the history, so you need to check varicella zoster virus IgG. If immune, reassure the patient. If not immune, you will give her varicella zoster immunoglobulin within 10 days from the contact. If the patient she come with rash, started rash, you will check this rash started when. Within 24 hours, you will give cyclovir if she is 20 weeks or more. If she is less than 20 weeks, you can consider cyclovir. It's unlicensed, but it can be used. How much is the dose? It's 800, 5 times per day for 7 days duration. I want to mention there is this is just a revision. Okay, this is just a revision. So if you listen for the first time, this could be difficult for the first time. But if someone already reads the guidelines, will be excellent revision for him. So it will be better for the someone who know. Before I'm preparing this PDF, I try to open again the guideline and read. Then I tell myself why I will not listen to the record. Why I will not listen to the record again. I open the record of my group, record group. I listened to my record with Randa Galil. This really was excellent. It was 15 minutes, you know. When I listen, I tell it's really excellent revision for the guideline. Again, I open the guideline and read. It will be easier and more easier for you to revise. The record was only 15 minutes, but contained very important information about the guideline. So again, patient contact, the first point, you will ask significant of contact. Second point, you will ask about the history of the varicella zoster infection before. If she tell I have infection, confirm it, doctor, I have infection in the past, so reassure the patient. If she tell you I am not sure, doctor, or I don't know, you send for varicella zoster IgG. If it is immune, reassure the patient. If not immune, you need to give the patient varicella zoster immunoglobulin, and we will talk how much time she should avoid contact with others, because this will be the questions of the next. If she is already developed rash, no rule for varicella zoster immunoglobulin. So the rash, you need to give the patient cyclovir. If the rash developed in the first 24 hours, you can give cyclovir. If the patient 20 weeks or more, if less than 20 weeks, you can consider cyclovir. If the patient develop rash more than 24 hours, so no rule for the cyclovir, just symptomatic treatment and avoid contact with other pregnant women and children. Okay, next, last question for you, Dr. Sumaya.
Pregnant women, 14 weeks, she come for ANC. She give history of contact to child with chickenpox. Patient don't have any history of chickenpox before. You check varicella immunoglobulin when result of serology will be available. 24 to 48 hours.
Yes, it will be. Was a question in MRCOG, I think 1 year before. They are giving a scenario about one patient, and they put in the question that they send for varicella zoster virus IgG to check it's immune or no. And in the options, they wrote, give now varicella zoster immunoglobulin now. Other option, wait for the result. You are in the exam, you don't remember, you just remember that if the patient not immune, you will give her varicella zoster immunoglobulin. but now no result. So I will give her, or I will wait the result. Sure, you will wait the result, because we tell maybe the patient immune, so no need, reassure her. And the result will take how many days? It can take 1 to 2 days, okay? And you can give varicella zoster immunoglobulin until the 10 days. So in the exam, this was a question in MRCBI written exam. So what you would do, you will give or you will wait. So I will wait the result. Sometimes the patient, she can have blood sample from antenatal care. It can take a few hours. But the question in the exam was wait until the result. So you will wait until the result and you will check. If she is immune, you will reassure her. Mostly 80% of the pregnant women, they will be immunized. So you reassure her. If she is negative after 2 days, no problem. I can give her varicella zoster immunoglobulin within 10 days from the contact. 10 days. Within 10 days. Okay, another one. We will take another one. Thank you, Dr. Sumaya. Thank you, Dr. Sumaya. Well done.
Can I share, doctor? Can I share?
Dr. Nekhat, you didn't share today. Dr. Nekhat, correct?
Nikita, yes.
Nikita, Dr. Nikita. Okay, Dr. Nikita, you didn't share today, correct?
No, yes.
Okay.
Non-immune pregnant women who have been exposed to chickenpox should be managed as potentially infectious if they receive immunoglobulin from 8 to 28 days after exposure. The option is third one. Yeah.
So if the patient she received, you give her today, she is non-immune, you give her varicella zoster immunoglobulin, and she asks you, doctor, so how much I should avoid contact? She will tell her 8 to 28 days. Okay, so here is a question. So if this patient, she is receiving immunoglobulin A for any other condition, she needs for varicella zoster immunoglobulin or no?
Sorry, can you repeat that?
Some patients, they are receiving immunoglobulin A for other condition, other disease. She has a problem in her immunity and she is receiving varicella zoster immunoglobulin as a regular for her condition. And she come and she has contact with chickenpox. So you will give her or no?
We will check the IgG.
She is taken already.
Then
No.
we will not give.
No.
We will not give. If patient taking regularly immunoglobulin, she is taking immunoglobulin. So no need to give her. This is just, it will not come in the exam. It will be difficult, but it's mentioned in the guideline. Okay. So your patient will receive varicella zoster immunoglobulin and avoid contact 8 to 28 days after receive varicella zoster immunoglobulin. Next question.
Pregnant woman, 14 weeks. She comes for ANC, gives history of contact with child with chickenpox yesterday. She has history of contact with child with chickenpox last month and received immunoglobulin. She received immunoglobulin. What is the management for her? She has received last month. Is it give immunoglobulin if 4 weeks have elapsed since the last dose? Option C.
4 weeks. So if you have one patient, she received anti-D. She has a bleeding during a pregnancy. She is Rh negative, non-sensitized, and you give her anti-D because she started to bleed. And again, she bleed again. How many times, how many weeks you need again to repeat the anti-D?
For anti-D, it will be 6 weeks.
Okay, for a chickenpox, 3 weeks.
Okay.
So it's easy. It's easy to remember. I just put it, I know, because, you know, we are not a computer. We are a human. We are a human. We will forget easily. And the information is for part 2 really huge. This is the most difficult part during the preparation for MRCOG. So 6 and 3. 6 for anti-D and 3 for chickenpox. So if you are giving one patient anti-D, and she is, again, she bleed and you want to give her again, you will give her after 6 weeks. And any chickenpox, if one patient, she has exposure for chickenpox and you give her varicella zoster immunoglobulin, again, after some time, she come again and she tell you, doctor, I have contact, so she should receive or no? 3 weeks. So 3 weeks for chickenpox and 6 weeks for anti-D, just to remember, okay?
Okay, thank you, doctor.
Okay, next.
Non-immune pregnant women who have been exposed to chickenpox should be managed as potentially infectious if they do not receive immunoglobulin for 3 weeks, 8 to 21 days after exposure.
Oh, okay. So we have two patients. One patient already received varicella zoster immunoglobulin. She has contact. Another patient she didn't receive, but she has also exposure. So this patient will be infected for how many days? This one, 8 to 21 days. Just to make the longer duration for the patient to receive immunoglobulin. So 8 to 12 to 21 days for the one not received. But if she receives, the days will be prolonged to 28 days. Don't forget this information because this is could appear and you will confuse 8 to 21 or 8 to 28. You will give the longer duration for the patient to receive immunoglobulin. Remember this well. Okay, next.
So immunoglobulin will be given if the exposure is less than 10 days. Am I correct?
Yes. So if
What
she
if it is the
if
10th day? What if it is the 10th day? Do we give her?
this is the question I will give. This is the question.
Okay.
This is the overthinking what I will give. Okay, so 10 days I will give. Within 10 days I can give. Okay, I understand
Okay.
because the numbers and more than 35 in the last session. So no from black. So
Yes,
this
yes.
35,
Yes.
35 years zero. Okay, I know. Okay.
Patient developed chickenpox for the first time and she is worried that chickenpox can cause miscarriage and affect her baby. Regarding chickenpox, there is increased risk of miscarriage and there is chance of FVS about 1%. Not increased risk of miscarriage, but there is chance for fetal varicella syndrome about 1%. Increased risk of miscarriage and there is chance of FVS about 3%. There is no increased risk of miscarriage. So it will be B, no increased risk of miscarriage, but chance of FVS about 1%.
Varicella virus syndrome, fetal varicella syndrome, this will be about 1%. Chickenpox not increase the miscarriage. What about herpes simplex? Will increase the risk of
Herpes
miscarriage?
increases. Yes, herpes
No,
will increase.
no. Herpes not increase. Just to, I am collecting the information to make it easy for you. Herpes simplex.
Okay.
Why this question is important? Because any patient will come in the clinic. The first question she will ask you, this is will cause miscarriage or no? So chickenpox, herpes simplex clearly will not cause increased risk of miscarriage. Remember this well, because this could be a question. You can face this a question from your patient in the clinic. So this patient is no risk of miscarriage, but there is increased risk of fetal varicella syndrome. It's about 1%. Most of the infection will occur less than 28 weeks. So more than 28 weeks, it will not happen. The baby will have some features like skin scarring, eye defect. So it can be like small eyes, cataract, hypoplasia of the limbus, as in the picture. Neurological abnormalities like mental retardation, microcephaly, bowel and bladder and sphincter dysfunction. I didn't mention heart. I mentioned heart. I didn't mention. Correct or no? I didn't mention. So it's not okay.
No cardiac.
No cardiac. In the exam, he will put you. This is the feature of varicella, of fetal varicella syndrome, like this, and he will put congenital heart disease. So be careful. Just imagine. You can explain the features that will happen to the baby. So this baby can have skin scarring, can have neurological problem, can have eye problem, can have bowel problem, can have limb hypoplasia. This will be easy if you repeat it, if you listen to it, it will be easy. Sometimes
This
even the
infection
infection will not occur in the initial. It can be from subsequent reactivation in intrauterine. What is also the point is here? This is will be about 1%. 1% can happen. 1%. This is a question. If the patient asks you, doctor, this is chickenpox can affect me, you will tell her there is a chance of a syndrome called fetal varicella syndrome. This can happen only in 1%. This means that 99% your baby will not have any problems. You will ask you, doctor, yes, rubella mostly for the heart, but in this one, just to remember, because in the exam you will be confused. So it will be affect your baby. It is causing skin scarring, will cause bowel and bladder dysfunction, will cause limb hypoplasia, will cause cortical affection and like mental retardation and eye problem. Okay, next.
What if infection is after 28 weeks?
We will continue. Will not
Okay.
happen.
Regarding
Fetal varicella syndrome will not happen after 28 weeks. Okay, and after this we'll talk about what could be the infection happen to the baby. Okay, next.
regarding chickenpox and pregnancy, which of the following are indication for hospital assessment except respiratory symptoms, neurological symptoms, hemorrhagic rash, dense rash, crusted all over the rash, second half of pregnancy, asthmatic patient on corticosteroid 3 months previously. I think crusting over the rash. Crusting means it's already in the healing. So if there
Yes.
is crusting, then we will not indicate hospital assessment.
So hospital assessment for the patient, she has respiratory symptoms, neurological symptom, hemorrhagic rash, because this will be a problem in the coagulation profile of the patient. Dense rash either with mucosal hemorrhage or no mucosal hemorrhage. Second half of pregnancy is indication of hospital assessment. Patient asthmatic on corticosteroid 3 months previously. So crusted over, this will be happen normally. Patient will, after we tell she will be infectious 2 days and 5 days after appearance of the rash. The patient in the hospital, she will have MDT, will include obstetrician, fetal medicine specialist, virologist, neonatologist, according to her condition. The last two, the one with the patient smoking, patient smoking or chronic lung disease, she will need also hospital assessment and second half. But the first indication, respiratory and neurological symptoms and hemorrhagic rash, this should be in the hospital with high dependence unit. I think it's mentioned in the guidelines. You will need also to be in the hospital, take place appropriate symptoms neurological with intensive care access. Hospital with intensive care access, and when you transfer the patient to the hospital for assessment, should be the assessment done in the place where she will avoid contact with other pregnant women. Next.
Pregnant woman, 39 weeks, planned for induction of labor today for obstetric reason, started to have chickenpox today. When induction should be done? As planned, postponed induction at least 3 days, postponed induction at least 7 days. Postpone induction for 1 week.
Why?
But it is for obstetric reason. I think we should go as planned.
So what is your answer?
I'm not sure.
No, in the exam you will choose.
Okay, I'll go with postponed for at least 1 week. See.
Why?
Because during active chickenpox infection, we cannot deliver her by induction of labor and delivery. And in 1 week, there can be development
for antibodies to pass through the baby.
Okay, but there is no friend help in the exam.
Yeah, development of antibodies.
Nice. Okay, so we need to avoid at least 7 days from the onset of the rash, because this will allow passive transfer of the antibodies from the mother to the child. If in the exam he didn't give you that this is emergency, something emergency, he just tell for obstetric reason, any obstetric reason. Maybe this is something not urgent. We can postpone for 1 week, no problem. This can happen. But sometimes delivery could be needed for chickenpox. Did you know what is the condition we need to ask for immediate delivery for this patient in case of chickenpox? Which case? Immediate delivery.
Varicella pneumonia with respiratory failure.
Respiratory failure. Pneumonia, this could be still she is okay, she can breathing. Respiratory failure. So this patient, you need to deliver her, because if you deliver the patient, this will improve respiration for the patient. So the only case you need to deliver this patient emergency if this patient required ventilation, assisted ventilation, because this will be in case of pneumonia. So we need to postpone at least 7 days if it is possible. Okay, next.
If we are doing immediately, we can do a normal delivery.
If patient, okay, this is in front you. It's a question.
Okay,
No
previous
help,
patient.
no friend. You can't call. If they can give us options, only 2 questions, we can call a friend. It will be nice.
Previous patient, as in question 46, start labor pain the same night. What about her baby?
Yes, you just now tell me if she come in labor. You just now ask me. Yes, she come. You tell her we will postpone 7 days to allow passive transfer of the antibodies, but patient in the same day at night she come and she has labor pain, cervix fully dilated, and she deliver. What you will do?
After delivery, we should watch for her baby and give the baby immunoglobulins without acyclovir, B.
So option B, you choose B.
Yes.
Correct? Okay, so
Yes.
if the patient deliver before 7 days, or this patient after delivery, within 7 days after delivery, she developed also rash. Maybe she delivered, but she don't have chickenpox. But after delivery, also she started to have rash for any reason. This baby should receive varicella zoster immunoglobulin. This is the first one, with or without. So the essential one, varicella zoster immunoglobulin, and cyclovir may be added. What will happen, because you ask us a question? Well, the baby will have chickenpox. He will have varicella zoster virus infection in his first neonatal life. So he can get the infection from the mother. Either this can be transplacental, or during delivery of the baby, or from direct contact with the mother. So the baby will develop. We are talking, because you asked me after 28 weeks any problem, we are talking about this condition. If the baby delivered within 7 days from the infection of the mother, or the patient started to have chickenpox immediately after delivery in the first 7 days. So this can affect the baby, and the baby will have varicella zoster virus infection in his early neonatal life. A neonatology doctor, if you have one patient during antenatal care, she has chickenpox at any time during pregnancy, first trimester, second trimester, third trimester, you should inform the neonatology doctor, because we tell that there is risk of fetal varicella zoster syndrome. This is occurring about 1%. So the neonatology doctor should be informed at any patient in any gestational age she developed chickenpox. There is important question. She will ask you, I can breastfeed my baby, she has a chickenpox. So if she can breastfeed her baby, no problem. But if she has active lesion near to the nipple, so it's better to avoid breastfeed from her baby until this lesion crosses over, so it will not be infectious. So breastfeeding can be breastfeeding, yes, she can breastfeed her baby safely. But if she has lesion close to the nipple, so it's better to avoid breastfeeding until the lesion crosses over. This means that the lesion will not be infected. But the patient, she will express the milk. She will express the milk, because if she not express the milk, she will have engorgement, or even mastitis, or even abscess. So it's better to evacuate the milk. So this milk, this baby, she can receive or no? Yes, the baby can receive the milk if he is receiving varicella zoster immunoglobulin and or cyclovir. So if the baby on treatment, you can give him this milk. This is even for your daily life. Since you can face a case. I remember I delivered one patient with chickenpox. So she asked you a question. I can breastfeed my baby. You can breast your baby if no any lesion in the breast. If there is active lesion, it's better to wait until the lesion crosses over. The rash crosses over. And after this, you can express the milk. I will give to the baby or no, if the baby on treatment, either on varicella zoster immunoglobulin and or cyclovir. Sometimes following the primary infection, the virus will remain in the sensory nerve root ganglia, and reactivation can happen. This is called zoster, herpes zoster, or shingles. This is if the patient immunocompetent, and this is in covered area like thoracolumbar area, this is no problem. But if the patient himself immunocompromised, and he has this one in some area like in eyes, around the eyes, can be infected. What is the importance from these slides? I will tell you the importance. You are in the exam reading herpes zoster, so you are thinking that you are answering herpes simplex. This is happen. Once you see patient has herpes zoster, so from confusion in the exam, you are thinking it's herpes simplex. This is happen. It's really happen. Really happen. I'm telling you, this is really happen. So how I will remember? If you see zoster, remember this point. Forget herpes, because herpes making you confused regarding herpes. So zoster, this is chickenpox. Don't forget this information. Zoster is a chickenpox, because you are putting this one in the exam herpes. Herpes, then you are talking about herpes guideline. We are not here in the herpes guideline. We are here in the chickenpox. So zoster, herpes, zoster, will be chickenpox. What is the importance? The importance, he can give you a scenario about one patient with shingles or herpes zoster, and she is pregnant. What will be your action? You will have two different scenarios, and you can see this scenario in the box if you are solving frequent questions in the book. If she tell you, my husband, he has herpes or shingles, so you will deal with the same scenario of chickenpox. Same. Take history. You have history of chickenpox before. If she is not sure, you will check the varicella zoster IgG. If she is immune, reassure. If not immune, give her varicella zoster immunoglobulin. So same. So if she tell you, my husband, he has herpes zoster or shingles, so you will deal with the scenario as patient come in contact with the chickenpox. Same steps. Okay. But if she tell, I have shingles, so this patient already, she has already before, so no need for anything. Reassure the patient. She already have shingles, so this means this is secondary. She already has primary, and we mentioned before, any patient she has primary infection, this patient immune. So if she tell you, doctor, I have shingles, any problem, so this patient already immune. So what is the difference again? Remember, herpes zoster, this is for chickenpox. This is the first point, because I know that you are confusing with the herpes simplex. Second point, if the patient tell you, my husband, he have herpes zoster, herpes zoster or shingles, deal with herself, the patient to contact with the chickenpox. If she talking about herself, she has shingles or herpes zoster, this means that this is secondary infection, so this patient already immune, so the action will be reassure the patient. Okay, we will take the next question. I think this is just some information. Also, the same point is patient varicella immune status of the woman planning of a pregnancy or receiving a treatment can be determined by obtaining a past history of chickenpox by testing varicella antibodies by those who have no history or uncertain. Okay, this is for the immunity. Okay, next.
The risk of anaphylaxis is cited as less than 0.1%, 1%, 2%, 3%. Anaphylaxis is less than 0.1%.
Anaphylaxis, varicella zoster immunoglobulin. This is anaphylaxis because of varicella zoster, because this is incomplete questions. Because of varicella zoster immunoglobulin,
yes, immunoglobulin.
This will be about less than 0.1%. So this is very rare. This is the question I asked before. I don't remember for who. Patient with hypo gamma globulin who are receiving immunoglobulin A antibodies. This patient already in immunoglobulin, so you need to give her if she is already in regular therapy. Okay.
Yes.
And there is not many cases of blood-borne infection was reported, because this is from blood. But there is no any case of blood-borne infection was reported from varicella zoster immunoglobulin. Okay.
The incidence of pneumonia complicating varicella in pregnancy has been quoted at 10%.
10%. 10% is you will have pneumonia. We tell now chickenpox how it will affect the baby. We mentioned it can cause fetal varicella syndrome if the baby less than 28 weeks. It can cause varicella infection if the delivery occurs within 7 days, either within 7 days from appearance of the rash before delivery or 7 days after delivery. But for the mother, this can be a question. This can be a question in the exam. He will give you what is the effect, could be the possible complications. So pneumonia in the chest, hepatitis, so it's liver, encephalitis, so it's in the brain. They can give you three organ problems, and they will put you confusion too, and put another thing, so you will be confused. So I will remember how pneumonia in the chest, liver, hepatitis, encephalitis, so in the brain. So three things will be affected: pneumonia, hepatitis, and encephalitis. Pneumonia occur in about 10 to 14%, so it's almost 10%, and mortality, it's almost, make it same, 14, 14. For 14 patients who will develop pneumonia will die. So how much risk of development of pneumonia? I make it 10% usually, so I will remember easily in the exam. So 10 to 14, and the 14 patients from who develop pneumonia, they will die. Okay. There was a question about spinal and epidural. The recommendation, it's better to avoid any space in the skin when you are doing either spinal or epidural. Some tell it's better to do epidural because dura not penetrated, but they tell because of the large needles, this can also carry the risk of the infection. Spinal anesthesia also can carry the infection. So in the end, they mention it's better just to avoid the area of the skin free from the lesion when you are inserting. They are not putting which one will be safer. Each one have a risk of the transmission of the infection. So in the end, it's better to use the skin area outside should be free from the lesion when you are going to insert the needle. Next.
Patient came to the hospital with respiratory failure now. She's on ventilator. When review her notes, she visited her GP doctor few days before because she developed rash all over the body. So it's chickenpox.
In the exam, there is no help.
Context.
You have
yes.
You have 100. Okay, so now I am doing chickenpox. I'm Ghada with you. I'm doing chickenpox. So
Correct.
you know that this is chickenpox. But in the exam, he will not tell you, take care. Question number 50 is chickenpox. No.
Yes.
This will be a question in between. Will be a question in between. No one will alert you. So he can tell you, patient to come today with severe respiratory failure. Oh my God. And they put her in ventilator. Yes. And when we are looking into her notes, she was visited her GP few days because of rash. So he wanted
10
to
to
tell
14% can develop pneumonia.
Chickenpox can cause respiratory pneumonia in about 10 to 14% with mortality rate. 10 to 14% will develop and 14% will die from the pneumonia. So this is a case of a chickenpox. But in the exam, he will not call you and tell you this is the question of the chickenpox. This is the question of thrombotic reflexes. So you should be alert. Sometimes he can put the scenario by the reverse. He will not tell you how much chances she will have pneumonia. No, he give you a scenario about pneumonia and she has rash few days before. So this is a question of chickenpox. Thank you. This was the information from chickenpox Green Top Guideline, January 2015.
Thank you. Thank you, Dr. Ghada.
Dr. Ghada, I have a doubt, please. Can I ask, ma'am?
Just a minute. 1 minute. Just a minute.
Okay.
The point in the when I am started to prepare this guideline chickenpox, I read it for myself. I read again, and I know I read this guideline frequent times, not only one, frequent time. I find it difficult to remember what is the important points in the guideline. Again, I bring the chickenpox. It was recorded 2 times. One with Rhonda Galil. The other one, because I listen only with Rhonda because it was very shorter. I listened, it was really nice. It guided me, even I'm the one recording, but it was recording in 2017, but guide me about the important informations because I solve much questions before preparation, so I know what is the important questions that could appear. So again, I listen to the record. So the idea here in the YouTube channel that you do revision, but record this in recall group really very vital. You can listen. Some they are asking about PDF. Yes, you can read, but believe me, in the exam, whatever you are reading, usually you will forget. But when you listen, so today there is some doctors that do some questions wrong. You will remember even when they answer something wrong. You will remember easily in the exam. But if you just read, information is must. But today you see when we are listening to the now I tell, oh yes, anti-D, it will be given every 6 weeks. Chickenpox 3. We can't read this one in the PDF. You need to listen much to the recall groups record. This is really very important for the exam because it's contain most of the important questions appear in the box and important informations about information that could appear in the exam. So just listen and solve the questions. Still you have enough time for the exam. If you sit every day with your partner, you should have partner and solving the questions, and you can do revision, just revision for the important informations. Recall groups really enough for most of the guideline, because if you wanted to read one guideline, it's really very long. Okay, so now anyone wants to ask any question? I will try again. I will try to do one session more. Okay, I just wanted to do one session more. I will put the date. This will be the last session. And for the other, even who are going to February, I will continue with them. But just you need to follow the previous one, because we will not repeat the previous one, but we will continue. And I will do, inshallah, one session more. It will be important also about the exam, about very important topic will be appeared in the exam. Yes, Dr. Ankita.
Ma'am, please show question number 46 of chickenpox, ma'am.
Tell me what is the question, because I will
46, ma'am. Ma'am, in what condition patient of chickenpox should be admitted? So why the answer was second half of the pregnancy was there, ma'am? What is the risk in the second half of the pregnancy?
It's a guideline. It's not take care. I didn't mention hospital admission. I mentioned hospital assessment. There is difference between hospital admission and hospital assessment. You will send the patient for assessment, not admission. Okay, so it's in the guideline. One of the indication, second half of the pregnancy needed to be. I put it because I know it. This will be information. Maybe when you are reading the guideline, will not concentrate. But this is one of the indication for the hospital assessment.
Is there any reason behind this, ma'am?
I am not sure from the reasons. I can't give you justification, but we can search for the justification of this point. But I don't like to give anything I don't know. So I don't know specifically why the second half of the pregnancy. I'm not sure. But they want, if any patient will go for the hospital assessment, usually they will want to involve MDT team about her condition, like neonatology, the fetal medicine doctor, to check the baby, this baby affected by any problem, and usually this will be in the hospital.
Okay, ma'am. And ma'am, if the patient is active varicella infection and she is about to deliver, so we are gonna give IV acyclovir or immunoglobulin to the baby. Should I give yes, ma'am?
IV. If the patient she come in labor, I put in the slides, but I didn't comment on it. They are giving her also IV. If she come in labor and she has a chickenpox, one of the indication of IV, they are giving IV in labor if she deliver and she has chickenpox.
So mother should also receive IV acyclovir, ma'am.
Yes. I put it in the PDF, but sorry, maybe I didn't comment, but it's in the PDF.
So both in case of herpes or varicella, we should give IV acyclovir to the mother.
What, Dr. Ankita?
In case of both, yes, ma'am. In case of both herpes and varicella, if the patient is in active labor and primary infection, then we should give IV acyclovir in both cases, herpes and varicella.
Don't talk about herpes simplex. Don't talk about herpes simplex, because herpes simplex we can, if you want, we can do in the next session, because herpes simplex some questions when you need to give cyclovir IV, when you need to give cyclovir oral, when you need to give cyclovir in the first trimester, and again you need to do at 36 weeks. We can do questions about herpes, but don't mix the both. I can put it in the next session, inshallah.
Yes, ma'am. Also regarding
just a personal question, ma'am. Just last question, ma'am.
Hello. If you can give it chance.
Hello.
For
Just a
others
last
to
question.
ask.
Just a last question, ma'am. A personal
After
question.
this, you will pay. After, if you ask me, it will be paid. Okay. What is the question?
Ma'am, just a personal question. Ma'am, actually, during exam times, how much hour you spend in reading, ma'am? Like, how much hours per day you used to study before exams, ma'am?
I am reading all the day. I'm reading everything. I'm coming from work, only sitting in the last months. In the last months, I'm sitting with my friends from Pakistan. Almost just we need to eat, and we will take rest just to eat. We leave everything. We leave our children. We leave our family. We just sit for the exam, solving all the books. We solve not only the box solved maybe more than 5 times. I remember in the day of the exam, at the night of the exam, my partner tell me we can start Shirulata again. I tell her no, I will not solve again. Shirulata we solve maybe 10 times. I will not solve again. So repetition is important. Solving with your partner is important because you can remember easily from discussion. Okay.
Thank you very much for this.
Thank you, ma'am. Thank you.
Hello, doctor. Just one thing.
Dr. Gada, you talked about the book.
Hello, ma'am.
Yes.
Dr. Gada, this is Dr. Usma.
Hello, ma'am.
I just want to thank you immensely for telling us how many times we have to read the books. You were the only one who told this, that we have to read books so many times, and thank you very much for this information.
Books for the questions. I'm talking about the questions because every question will carry idea.
Yeah. So I want to ask one question. Patient is a